All right, Dr. Hutz, thank you for joining me today on a JawHacks podcast episode. Appreciate you coming on with me and giving me your time today.
Yeah, excited to be here, Ron. I think you have a great kind of podcast coming on. You've had some big speakers, so I'm a small fish in a big pond, but excited to share some of my perspectives.
Well, maybe a big fish in a big pond. I've heard nothing but good things about you from the clients that I've worked with who told me they were working with you, usually clients in the Chicago area. You were first introduced to me as like the big Chicago airway-centric ENT guy. But it turns out you're not just, well, you are an ENT, but you're what you call a comprehensive sleep medicine specialist. So you do not only ENT stuff, but you also do all sorts of airway stuff, including MMA surgeries. So could you just tell us a little bit about how you fit into the broader medical field and what makes you different?
Sure. Yeah. So, I mean, in general, in ENT residency, we learn everything about the airway, scoping, soft tissue, anatomic, physiologic things of the upper airway. Certainly not anywhere near the extent of the dental world, even the skeletal world. I mean, a lot of these things were not, at least in my training, weren't kind of educated to focus on. So I did a fellowship in sleep apnea surgery. So it was a hybrid fellowship at the University of Pennsylvania, where I got boarded in sleep medicine and then also sleep surgery. And so that was with a guy, Rod Dania, who's the kind of my fellowship director, who's at University of Pennsylvania, who also does kind of comprehensive sleep, does everything from, Inspire implants to nasal surgery to soft tissue to MMAs and SARPE. And during my fellowship training, I got to work with Mariana Evans. So Mariana, who I know probably most of your listeners are aware of, is just a phenomenal, I don't know what you would, airway orthodontist. That she worked a lot with Raj at Penn, and so I got to shadow her in her clinic, start learning more about that, and then kind of got trained in kind of SARPE techniques and MMA, and then established at Rush University Medical Center in Chicago. So, my practice in Chicago is, pretty much 100% sleep apnea airway. So UARS, sleep apnea. I know UARS is kind of a hot topic.
It's like the Pluto of
it's kind of
stuff.
this,
Does it exist? Is it a planet? Is it not a planet?
Yeah, exactly. Everyone that doesn't have sleep apnea, but, maybe has some of these skeletal deficiencies, we just kind of clump into UARS. So whether or not we're missing the boat on some of these patients, but basically, my whole, practice predominantly is CPAP alternatives. So, a lot of these patients that come in to see me, you get a diagnosis of sleep apnea, for multiple reasons. Insurance purposes, require it oftentimes before you do any kind of surgery. But also, for a lot of these patients, CPAP is still the most effective option. So most effective, least amount of risk. The issue obviously is that about 50% of people can't tolerate CPAP. So but for a lot of patients, even, 25, 30-year-olds, they have resolution of their, sleep apnea symptoms and they stay on CPAP and they're like, whatever, it's a small price to pay for, waking up feeling refreshed.
Could I interrupt you briefly on the CPAP question?
Yeah, please.
Offline, we were talking about muscle tonality. Sure, CPAP could provide immediate effective solution to sleep disordered breathing. But is it the case, though, that CPAP kind of weakens the muscles over time and can lose its effectiveness over time so that it's more of a short-term solution that can have longer-term negative consequences, or is that bullcrap?
So that's an interesting question. I've had other patients ask me that. I personally have never seen any data to support that. Okay. So, I mean, the concept of that is like a ventilator, right? So patients that are on a ventilator, they're intubated, they're not attempting to breathe on their own. So that for sure causes people to decompensate, their diaphragm weakens and other things if you're on a long-term vent. I personally have not seen that, data. I've never seen a long-term study supporting that. So I don't, I understand why people may think that, but, you're wearing it for 7 hours a night and the rest of the day, your muscle tone is your own tone and you're going about the day and you're chewing and you're eating and you're breathing and doing all these other things. So I would personally disagree with that. But again, I think we also just don't have studies to support either way.
Yeah, that's fine. And when you say CPAP is currently the most effective treatment, you're saying that the data does support the notion that a CPAP gives a better improvement in sleep disordered breathing than, even an MMA, for example?
Yeah. So, I mean, I think if you look at all comers, and again, we have to look at patients, not just ones that are of normal weight that have skeletal deficiencies. You have the obese patients, morbidly obese, all these patients. The MMA literature, systematic reviews and meta-analyses say, one that came out a couple of years back was, I think, about an 85% surgical success rate with MMA, meaning their AHI ends up being less than 15 and reduced by at least 50%. And sleep apnea cure was about 34 to 40%, where it's actually less than 5. So that was just kind of the broad data across. And I think, sure, there are plenty of patients that their residual AHIs are a little bit higher, but in general, I see a ton of patients where their residual AHI is 1 or 2. And even with MMAs, you can advance them as far as you want. There's probably still going to be higher residual AHIs. You can take someone from 77 down to 12, and they're asymptomatic. But I think CPAP just kind of blows open the whole airway, so it just indiscriminately holds everything open. So I think I personally think it's still more effective. The problem is most people don't want to wear it. So and I think MMA it's a little bit of a Band-Aid, right? It's like insulin for diabetes. You're not curing the sleep apnea, you're just treating it appropriately. Whereas MMA, you're focusing on a one and done. The sleep apnea is no longer there. You don't have to do anything else for it. So there's 2 different ways to treat it.
Understood. And thank you for that explanation. Yeah, let's get back on track here about you and what makes you different. So you described yourself as being non-CPAP based therapies for sleep apnea. What does a typical month of surgeries look like for you? What percentage would be like MARPE surgical assists? What percentage would be nasal surgeries or other soft tissue sleep apnea surgeries? And then what percentage would be MMA surgeries?
Sure. So, a big part of the practice, and I know some other folks feel strongly about DISE, but I still like to do a sleep endoscopy. So a drug-induced sleep endoscopy, I still like to do before, almost every case, including MMAs, where, you essentially put the patient to sleep under propofol, you slowly titrate up, look with a camera in their airway, and kind of get an idea of what's going on structurally. So I still do a ton of DISE, probably, maybe 30 a month of those cases as kind of a prerequisite before we do any other kind of surgery.
I just saw Michael Gunson, by the way, for my own case to look at whether or not he would consider operating on me, whether I was a candidate. And he said that he really wants me to do a DISE before I proceed. So you're definitely not the only A-lister in the field who likes DISE. It makes perfect sense. Maybe you could briefly explain what DISE is. And also, why do some people consider it controversial? Because to me, it's very common sense that it would be a useful metric.
Yeah, so I think what a sleep endoscopy is essentially a sedated airway exam. So, the patient comes into the operating room. Some people can do it in like some kind of surgical suite or even clinic. You give the patient propofol. In the US, it's propofol. Other people use, Versed or midazolam, other types of medications. But you slowly deepen them until they get to a point where they're starting to have sleep apnea, snoring, sleep apnea. And then you look with a camera through the nose at the back of the throat, and you look at the entire airway from the soft palate to the side walls, to the tongue base, to the epiglottis, to see what is going on when they're having their sleep apnea. So it gives you an idea of if there are certain structures that are collapsing, is there a bunch of redundant soft tissue that might be blocking if they have big lingual tonsils, or, some patients will have, it's less common, but like a floppy epiglottis that is kind of closing over the airway. So, it takes about 20 minutes total. It's a relatively short exam. The issue or the controversy about it is that it can be highly variable. So it depends a lot on the anesthesiologist, so how much propofol you're giving, because if you oversedate someone, everyone's airway is going to collapse. So like everyone, I don't care if you have 0 sleep apnea, it's going to look like, you have an AHI of 100. If you undersedate them, you're not going to collapse things enough. So that's one thing. The other thing is there have been studies that show it reproduces stage 2 sleep. So, people have done a PSG or sleep study under propofol. And so you reproduce at least light sleep, but you can't reproduce REM with propofol. So it's not a perfect, view of the entire night, but I still think it gives a decent kind of overview of the anatomy and physiology.
And when it comes to it not being able to produce REM, Does that mean it would be more likely to give you false negatives because in REM, people are more likely to have apneas? At least that's what Dr. Anil Rama explained to me, was that REM is kind of the most problematic sleep stage for a lot of these incidents.
Yeah.
So would that be the concern?
I mean, no, it's more of like the sleep apnea is going to be worse during REM. So you can sedate someone enough to like show what their airway would look like when they're having apneic episodes, but like it's not going to show how much worse it gets during, that, 10 to 20% of the night they're in REM sleep. So, that's certainly a part of it, but you can still get people deep enough to show kind of what's going on in their airway.
Yeah.
But then there's things like you're on your back versus like, do you sleep on your stomach or your side? So, trying to figure out patient's body position and have them try to be in a natural sleep position when you're doing the sleep endoscopy can also sometimes be useful.
Yeah, that makes sense. Although I find that most people move around a lot when they sleep. They'll spend some time on the side, some time on the back. I personally, no matter how bad back sleeping is for me, and it is bad, my body will still go there. And some people think that the back is the most natural sleep posture just because it evenly distributes, force along the back and the spine, whereas side sleeping is inherently kind of unhealthy in its asymmetry of forces. So I think from a common sense perspective, the DISE makes a lot of sense. I think it's definitely useful. And then do you also when you're doing the DISE, do you take their mandible and kind of slide it forward to see if that resolves the pharyngeal airway issue?
I do. Yeah. So I do what's called an oral appliance simulation or mandibular advancement simulation. So, you can gently kind of grab their lower teeth and chin. You don't want to jaw thrust someone because that's going to arouse them and then their airway is going to look awesome because they're not sleeping anymore.
Right.
So you kind of gently pull the jaw forward and you can see, okay, how much does this pull the sidewalls out? How much does this move the tongue out of the way? Does the soft palate open up? And that can be an example, of one, would they tolerate something like an oral appliance device? So if you have an older patient that, is intolerant to CPAP, maybe something like an oral appliance, which again has all of its own inherent, downsides to it. But like, are you going to do an MMA on a 75-year-old that has heart failure? Probably not. So there are other types of interventions that you can do. And then it also, maybe gives some data about what would an MMA kind of look like if you pull the jaw forward, say a centimeter, or and again, it's not moving the upper jaw, so you have to take a little bit with a grain of salt. It's certainly an MMA is going to make a bigger difference on the patient's airway than just a mandibular advancement simulation.
Yeah. How nerdy are you on the brain science of sleep apnea and your understanding of why it is that REM sleep is you have more apneas in that stage of sleep? I asked Dr. Rama this question, and it wasn't too clear. He didn't really have too solid of an answer on that. One thing I've noticed in my own experience is that usually, the way I got into this whole space was that I would go to bed sleeping great, and then I would wake up with these really nasty headaches. But it was a little bit more precise than that. I would actually go to bed feeling great, wake up sometime at 2 or 3, also feeling great, go to bed at 4-ish, wake up again at 6 or 7 feeling awful. And that was also the time when I was having really vivid dreams. So presumably a REM stage of sleep.
Yeah.
So the whole REM stage being more problematic for sleep apnea is very personal to me, but I don't have any understanding of why it is that stage of sleep is so difficult on the airway.
So I'm certainly not, they're experts in airway physiology much, much better than me. But I think kind of in the most rudimentary kind of understanding of it is that your entire body is essentially paralyzed during REM, other than the eyes and the diaphragm. So your upper airway muscle tone is kind of the most decreased during REM sleep. So if you have a smaller airway to begin with, if you have skeletal deficiencies, those are exacerbated during REM. At least that's kind of my understanding, is that you have the least amount of muscle tone supporting the patency of the airway or the openness of the airway during REM.
And what's the relationship between that being the case and also the fact that we tend to dream more in REM? Is the paralysis a kind of prevention from you acting out your dreams? Is that
Absolutely.
What's going on?
Yeah. So, I mean, there are patients that have what's called REM behavior disorder, where their body does not paralyze and they will act out their dreams and they can get injured, try to climb out a window, go out their front door, all these different things where or hitting your bed partner is the most common thing. So that's kind of the biggest thing, is it allows you to dream without acting out, everything that you're doing.
Yeah, that's very interesting. Um, I would like to pivot now into getting into the weeds a bit more about MARPE surgical assisting.
Yeah.
It's a very controversial open area of discussion on my channel as to what is the appropriate amount of assist to include with a given MARPE. My simple understanding of how to get a MARPE to work is strength of the appliance versus resistance from the skull. And the surgical assist is attacking the resistance of the skull variable. Whereas, strength of the appliance, now we're talking, which is the best appliance? Is it a Partners Dental Custom MARPE? Is it an FME? Is it a TPD from Casey Lee? Is it a tandem MSE? We're not talking about that right now.
Yeah.
We're talking about the other side of the equation, how to weaken the skull so that it resists the expander less, and you can get a nice, a large magnitude of expansion, or a desirable amount of expansion, let's call it. Maybe not a large magnitude, but the amount that you want, as well as a symmetric kind of expansion. And then we're also balancing what is the sort of vector of that expansion. Is it anterior? Is it posterior? Is it going up the nose? Is it being terminated here because of buttress cuts? There's a lot that we're juggling.
Yeah.
And the anatomy is complicated. So I want to ask you a little bit about that. What is like your big picture understanding of how to release a skull to allow a MARPE to do its thing?
Yeah. So that's a loaded question with a lot of avenues to consider. So, in my practice, I still recommend attempting a non-surgical MARPE before we go into surgery. So I don't know if you know this, Ron. I actually did a MARPE to myself 2 years ago.
I didn't know that. Did you install it yourself?
So I had an orthodontist. There's a really great orthodontist, Yi-Wei Huang, who's in the Gold Coast in Chicago, that I work with on a lot of the skeletal surgery and surgical assist. So I'm studying all of this, and I see this every day, and I'm like, I have a narrow high arch palate, and I played sports my whole life and have nasal restriction, and maybe unrefreshing sleep. Although I messed around with sleep studies and fellowship that were negative. So I'm like, well, I might as well walk the walk if I'm going to talk the talk to all my patients. So I'll pull up a picture that I have of myself for you, and I can just show it to you here. But so I did a MARPE about 2 years ago, and this is here. Let's see if we can get this on the.
Oh, that's gnarly, man.
So that was, about 8 millimeters of expansion that I ended up getting, and about 4 millimeters of nasal expansion. So I got at the piriforms, my piriforms expanded 4 millimeters, and then the intermolar width was about 8 millimeters.
When you said your piriform expanded 4 millimeters, where are you measuring from?
So that's measuring from the side. Yeah, exactly. So the side of the piriforms there expanded 4 millimeters apart on the pre and post, which in a small space is a big difference. And I tell people I had about 1,000% improvement in nasal breathing. I mean, it was like night and day, where I go to sleep without needing to be congested. I wake up and my nose is clear, and I got COVID since then, and had all the symptoms without any congestion. It was actually really strange how much space. So I had personally a very positive experience with it. I opened up non-surgically. And so in a lot of these patients with how good these MARPEs are getting, I still recommend, hey, I have a protocol with Dr. Huang where, we'll try to have someone turn for about, 3 to 4 weeks. And if they see a diastema and they open, fabulous. If they don't, they unturn and we go to surgical assist. So I still think, maybe there are people like Dr. Yoon and Dr. Evans who, say they're getting, 80+% success rates or more, and even in adult males. So I think it's worth a shot.
Yeah. Going
to the kind of the question that you asked, very controversial question, and we don't really know the answer to it yet. So, my whole kind of career has been kind of educating my ENT colleagues about the maxilla and how important it is to because we all treat nasal obstruction in ENT. And in general, ENTs, we look in the nose when we treat nasal obstruction. We see there's a deviated septum, or the turbinates are swollen, or they have polyps or chronic sinusitis, but we're not looking in the mouth. We're not seeing, okay, this guy's got a really narrow maxilla. That's why his piriforms are narrow. That's why the whole nasal cavity, I explain to patients your septum's straight, but you're living in a studio apartment. So no matter how much we rearrange the furniture, the room is still too small to begin with. So that's been my focus. So we have our International Surgical Sleep Society. The ISSS is our major international sleep surgery society. And I was talking to a bunch of other kind of ENT and craniofacial surgeons that do SARPs. And that's kind of the debate is we don't know yet in which patients we need to cut which sutures and what type of MARPE we should be using. So, the way that I, in my practice, am currently doing it is continuing to evolve, but I will use an endoscope, and I can talk about this a little bit more, but basically we'll cut the mid-palatal suture. And then instead of releasing a full Lafort, I will only make a little cut on the lateral buttress on each side. So I take, I wish I have some skulls down.
Okay.
You got it right there. Yeah.
Is that here?
So the lateral buttress is all the way lateral, kind of right under the zygoma.
Deep in here?
Right where it makes the corner. Yeah. So I just take a little triangular wedge out of that bone on each side because the lateral buttress seems to be a really strong bone, especially in adult males, that will kind of resist how much lateral expansion you can get. So if you're making a straight Lafort, Ron, like straight across, just take that area on the side right here and basically just take like a 1 millimeter wedge of bone out, kind of where you would be making your Lafort. But I don't cut the piriforms kind of medially.
It's interesting when you point this particular spot out, it's almost projecting out like a pillar in a foundation of a house that's like a post that's directly resisting the expander. Because it's the orientation of it is like the expander is literally hitting this.
And that's what we found, especially in some of the early ones where we tried to only release the mid-palatal suture, is you could get a millimeter or 2 or maybe 3, and then it just hits the sides and it will not release any further. So the thought is that lateral buttress is a really, really thick bone that is resisting the lateral kind of movement. So that's what I cut. I still release the pterygomaxillary sutures, and that's another controversial one. So I'll do the same incision. So I make kind of 3 small incisions, one under the lip in the middle, one under the lip on each side. And then through this little incision under the side, I'll go back and use a little osteotome and kind of release the pterygomaxillary suture in the back.
Yeah, let me, what I'd like to do, if it's okay, I'm going to screen share an anatomical image just so that we can all get clear on this once and for all.
Yeah, that's perfect. And then will I have the ability to kind of...
well, you can guide my scroller. So, yeah, this may be not a great image.
That's okay. But yeah, so you can see...
Here, better?
Yeah. That's a good example of the pterygomaxillary suture there. So through this little, incision, you can slide in this osteotome, and you want to just release the pterygomaxillary suture there to, again, allow posterior expansion.
Is that this area right here where this yellow line is?
So that's the posterior aspect of maxilla being connected to the pterygoid plates, which is what you're kind of showing there.
Not showing it well because I'm screwing up my trackpad here, but freaking Butterfingers over here.
Oh, you're good.
So
that area there is controversial, and I do have some colleagues that are not releasing that and seem to still be getting pretty good posterior expansion. And one of the things that I'm looking at doing right now is trying to assemble a group of surgeons that are doing these SARPs and just bring all our data together, and we can analyze. There's certain patients or certain surgeons that are not cutting the pterygomaxillary sutures. Do they have less posterior expansion, or if you're doing more of the dome technique where you're not kind of completely cutting the mid-palatal suture, is that affecting things? Or are the MARPEs so good now that all of this is obsolete? Because no matter what you do, as long as it's released enough, the MARPE is going to do the rest of the work. So those are the kind of the questions that we still don't know.
When you do this pterygomaxillary suture cut, are you coming from the bottom up, straight up, or are you coming across it? How deep do you go? What tool do you use? How is that done?
So you use a pterygoid osteotome. So it's basically kind of similar to what that instrument looks like, where it's got a little curve to the end of it. And so that little curve slides around the back half of the maxilla, kind of similar to what this looks like. And you're coming in from the side and you're angling kind of down, and you put your finger in the mouth. So you're hitting this thing until you can feel your finger behind the maxilla, and your osteotome is kind of tapping the finger without going through the mucosa. So then you know that you've kind of fully separated it on each side.
And is that an electronic tool, or is it a power tool, or are you cutting it manually?
So it's essentially just an osteotome is just like a chisel, a curved chisel. So that's still there are some certain techniques that I'm kind of interested in exploring, where there's a guy in Spain who's doing it transorally, where he uses a little piezo to kind of make an incision from inside the mouth where you're coming up on that, which is a lot, probably a little bit less of a blind cut, which is always kind of, whenever you're releasing the pterygoids, that's not a resident move that I let them do blindly.
Why is that because there's blood vessels, and is it innervated back there?
Why is mostly, it? So the internal maxillary artery is the huge artery that sits essentially right behind the maxilla. And it kind of enters just above where the inferior border of that pterygomaxillary suture is. So if you pull up maybe the far left, upper left, I don't know if it'll,
maybe
but basically here. if you try to release the pterygoids too high, you can transect that blood vessel. So you can see that. It's the one in the very middle of the screen. No, it's behind the maxilla. So you see that
this one
vessel. Yeah, exactly. So that blood vessel is going to run right behind the pterygoids, but up higher. So that's why we like right where
this central branch, or is it one of the
central branch? No. So that internal maxillary artery is a huge artery that goes in. So you just make your cut low, and you're not anywhere close to that. But if you, for some reason, accidentally aim kind of superiorly, you could technically injure that internal maxillary artery, which then is, calling the interventional radiology team to embolize, and there's not really any good access to that. So you can't cauterize anything during surgery.
Yeah, and that's definitely one reason why the pterygomaxillary sutures are never cut in office by orthodontists, like the midline or like the ANS.
Correct. Exactly. So I mean, the big question that we still have is what are those sutures to cut? And I still think for men, the mid-palatal suture can be so kind of thickly interdigitated that it's so attached that it needs to be released in some way, shape, or form. So the MARPE can kind of pull the interdigitations apart. But if you can't do that, then I think at least doing something to release that mid-palatal suture at a bare minimum is necessary. And then really the question is, some patients, maybe you don't need to cut the lateral the lateral buttress. And the question is, we don't know how to personalize the surgery. So in my opinion is it doesn't need to be a one size fits all. I don't think a single surgery on every single patient is probably necessary. So the goal is figuring out, like, is there a way through bone density mapping, or like figuring out how thick someone's bone is, or some other matter that we still haven't figured out yet, to say, oh yeah, Ron, in order to expand your palate, we only need to cut the mid-palatal suture, and actually just in the front. Like the back is weak enough where it's going to separate with the MARPE, or, we actually just need to release the pterygoids. That's the part, or just the buttresses. So I think that's the end goal, is figuring out. And in all honesty, with how strong the MARPEs are getting, I may be obsolete at some point from a surgical assist perspective. If they're good enough, like, I would recommend, why would a patient have a surgery that has, a risk of complications if you can just turn a screw and it's strong enough to expand?
Yeah, Casey Lee reached out to me a couple of weeks ago, and he said that he's seen FME fail already. And FME is supposed to be like the poster child for the super strong appliance that doesn't require the surgical assist. But he said he's seen it fail, and that he's not optimistic that the surgical assist is ever going to be obsolete.
Yeah.
He didn't say that, but that was his sentiment.
Yeah. Yeah. And maybe that is true. But if you look at where the field of orthodontics has come, like I was talking to Mariana, she gave a really nice talk a couple months ago in Chicago. And, even going from tooth-borne expanders in 2012 to MSCs with bone anchorage to custom, to MARPEs, and now custom MARPEs, and like 8 TADs. And that's been in a span of 5 to 10 years.
Yeah.
So with how quickly things are accelerating and how good, AI and some of these other things are getting, like, I think it's going to continue to improve. I don't know if it'll ever be, obsolete, probably not in certain patients, but I think you'll be able to capture more and more patients non-surgically as technology gets better.
Yeah. Imagine a MARPE that had electronic sensors in it that told you where the appliance was encountering resistances and from what angle they were coming. And even if it was just giving you information that you could use to do a more targeted surgical assist, but then maybe someday imagine a MARPE that kind of adjusted itself somehow to respond asymmetrically to asymmetrical resistance forces, right?
Yeah.
But
It sounds crazy, but I think there is the technology to do that. So I think you need to get on that and start patenting that, Ron.
I'm just a lowly YouTuber, my friend. So in terms of midline cuts, you also mentioned earlier that you do use an endoscope. How do you use an endoscope when you're doing surgical assists? Little preface to that question. People used to say that Casey Lee would cut down the midline from the nose using an endoscope guide. But now people are saying, and Casey has never confirmed either way, the endoscope is just used as an extra set of eyes to guide a piezotome coming in from the palate from underneath to make sure it doesn't puncture through the mucosa of the nasal floor. So what are your thoughts on all that? How do you use an endoscope?
Yeah, so I've heard rumors of such things as well, that he's kind of doing intraoral incisions now. So the way that when I was in fellowship with Raj, everybody has acronyms, so I'm not a big acronym guy, but it's called 2PEN, so posterior palatal expansion via subnasal endoscopy. And so we published a paper a couple years ago on it, but there's kind of two different ways I do it depending on the patient. One of the newer techniques that there's a guy, Eric Thuler, who's a Brazilian sleep surgeon, who is really good endoscopically, started doing, which I've transitioned to, is you can actually do it through a septoplasty approach. So what I mean by that is you can make a little incision inside the nostril, and the septum is the cartilage drywall between the two sides. And especially if the patient's never had any nasal surgery before, you can raise up two flaps, the mucosa on either side of the septum, and you can bring in an endoscope and your piezo saw within these two flaps and cut the mid-palatal suture between the two flaps. So there's not even any incisions kind of in the nasal floor. It's kind of through those two flaps from above. So especially if the patient has a really deviated septum that needs to be addressed anyway, you can address both at the same time. So you can fix their septum and cut the suture. The kind of the traditional 2PEN approach that we've used is you make an incision kind of from lateral incisor to lateral incisor underneath the upper lip. And you can actually raise the mucosa up and the entire floor of the nasal cavity. So you can come in and lift, almost like you're lifting up a carpet, the septum off of the maxillary crest and the mucosa off the floor. And then you just pull a retractor up, bring an endoscope in, and then you can see the maxillary crest, and you just cut from front to back, kind of under the entire floor of the nasal cavity, and then you just lay everything back down.
Is that like what a maxillofacial surgeon would do if he was doing a segmental Lefort? He would lift up the whole thing there and then segment the maxilla from above like that?
No. So the way you would do a segment is you'll down fracture the maxilla before you do that. So you wouldn't do it endoscopically. So you would actually completely make your Lefort cut and you would down fracture the jaw. And then now once it's down here, then you make your cuts. So it's kind of like that without actually down fracturing the jaw. So instead of breaking things apart, where now if you expand, you're not going to expand the nasal cavity. This is leaving all of the nasal cavity and piriform and medial buttress, all these bones intact, and you're just releasing the mid-palatal suture. So similar concept, but without having to fully kind of separate the upper jaw from the mid-face, if that makes sense.
Right. No, that makes perfect sense. Yeah, I shadowed Dr. Alfie in Houston. I watched him do 3 MMAs, all on the same day, by the way.
Yeah. I saw the podcast. That's pretty gnarly.
It was gnarly. And one thing that he would do is when he had the maxilla dropped and he had the nasal, the piriform area exposed with everything above it kind of peeled up, so to speak, but also the maxilla dropped, as you were just explaining, he would actually shave the piriform rim at the bottom in order to remove what he said were excess and unnecessary bony structures along the base of the piriform rim there. Yep. And he did that as a way of improving nasal breathing for the patient. What do you think about that as a tool or as a procedure?
Yeah, so I think it's pretty common. So that I do the same thing with my MMAs. So you can take, what's called a pineapple burr. There's a bunch of different ways to do it. I actually went to Mike Gunson's orthodontic course a couple weeks back, which was phenomenal. It was he's a really smart dude and good at what he does. So that's awesome that you're seeing him. But he takes an actual reciprocating saw and he'll just take a big wedge of bone out to kind of lower the entire floor of the piriform and nasal cavity. I use a pineapple burr to kind of lower that. So I think a lot of people do that kind of like, opening up the nasal cavity, especially if you're going to impact the upper jaw a little bit, you want to increase that space. So I definitely think that's a good technique to use. And that's not going to be the same as a MARPE, because you're only increasing the floor of the nasal cavity. But I do think that definitely helps improve nasal breathing and kind of where the septum sits post-operatively. So I definitely recommend that.
What other impressions did you have of Dr. Gunson from that? What else did you learn in that meeting? Like big takeaways for you?
So many things. It's a really good 5-day course for kind of orthodontists and kind of craniofacial surgeons. But I think the biggest thing for me is just kind of his reverence of the TMJ, the joint. The way he plates the mandible and kind of seats the condyle is, he has such incredible attention to detail, and the way he, puts his plates and screws in a very kind of particular way. I think it's something that there's, not a lot of surgeons that kind of baby the condyle as much as he does. And obviously there's a good reason for that, where he kind of bends everything to fit the contours of the bone, where it's not kind of changing the place of the mandible.
Right. What did you learn from him about how to do a beautiful jaw surgery and how to manage aesthetics, the aesthetic versus airway tension when you're doing a jaw surgery?
Yeah, it's interesting. He, his focus and something that Bill Arnett, who kind of trained him and is kind of, one of the godfathers of orthodontic surgery, especially from a cosmetic perspective, is just kind of bringing the patient's jaws to kind of what the facial norms should be. So, he does all these different techniques in clinic where you're advancing the upper jaw just as much as the upper lip needs to be supported, making sure that the lower lip has enough support and you can have adequate kind of lip, closure and posture after surgery. How to change the facial third heights. So like if the lower chin is too long, kind of making the chin a little bit shorter to allow the upper lip to close better. From a cosmetic perspective, it's pretty impressive. My practice is very different than his, because mine is kind of more sleep surgery focused. So obviously the cosmesis is important, but less of a factor. But I think one of the interesting things that he said was, if you need to advance the jaws beyond the aesthetic norms, you're probably missing something. So like if you need to cure sleep apnea by over advancing someone, we're probably missing the fact that this guy has excess soft tissue or poor muscle tone, or is, genetically predisposed to sleep apnea. So I think that was an interesting comment too, where he's like, it's really important to be evaluating the entire airway and not, over advancing someone.
That's interesting.
What their facial norms will tolerate.
Yeah, that standard kind of makes you reflect back on natural law, almost like thinking in terms of evolution or in terms of like an intelligent designer, where, we have this structure that we were supposed to achieve genetically if all had gone according to plan. But obviously for patients that are underdeveloped for whatever reason, environment or genetic, it didn't go to plan. And if it had gone to plan, presumably that would be enough for them to function and breathe normally. So we shouldn't have to go past that for them to have normal function. The normal structure should yield the normal function. It's kind of a almost like a classical kind of approach.
Yeah, no, exactly. I think that was his focus too. And the big question is though, that like, what are our norms? And that's a big question, because, are our norms our 16th century, jaws, or is that what we're supposed to be, getting back to? And from a certain extent, yes. But there's other thoughts, and I don't, this is out of my field of expertise, but, is certain parts of our brain developing further where like, you can't support certain aspects of it. There's a reason other than environmental that things are changing. But no, I totally agree. I think if you're advancing beyond that, we're probably missing something.
So when you said that cosmesis is not as big of a factor in your practice, is that because when you do MMAs, it's for people that are like on the verge of like death due to sleep apnea? They're just totally not functioning. They're handicapped, and they are not as concerned about cosmesis as someone else.
Yeah, I mean, so I think, my practice is very different than Gunson's, is very different than Alfie's. Like I'm at an academic center where I'm treating patients from Medicaid to billionaires. So, we're not going to do, cheek implants or cosmetic rhinoplasties or all these different things. Like these patients have an AHI of 80, and, they're not going to be able to afford cosmetic dentistry and all this other ortho. We're just trying to help them function and breathe. So, not that I don't, obviously I'm still paying attention to all those things, but, patients aren't coming to me to do like a cosmetic jaw surgery. It's more of for functional purposes, and restoring the cosmetic norms is obviously a part of that, but it's not, I'm not interested in being a plastic surgeon. I think by restoring their function, people get cosmetically better, if that makes sense. But it's just,
but also, I think part of what you're saying is that Dr. Gunson is out of network with all insurance providers, but you're working at a facility where you take insurance, and your hands are tied to some degree by the financial side of things.
Yeah. And I try to, I have not had an MMA or SARPE not get covered by insurance. So that's like a goal of mine, is to, how can we bring this to more people, not just the people that can afford, this type of stuff. Yeah. But I think, so that's where it's like trying to find that fine line. Like I'm focused on wanting to make people, look better, but the primary goal is getting them to breathe better and treating their sleep apnea for me.
Yeah. Along this vein, I wanted to ask you about the cheekbones. Second, when it comes to MARPE and doing the lateral buttress wedge cuts. But first, while we're on the subject, cheekbones and MMA. Dr. Gunson did offer cheekbone implants. He said it would be key to maintaining facial balance for me so that I didn't look too bottom heavy if I were to do an advancement. Ben Wallin said that there would be no cheekbone implants. I don't think he does them. And then Dr. Bell took a more nuanced view where he said that when he grafts the Lefort ledge area, right, he said that essentially does create a cheekbone implant when you stuff this area here with grafting material, that sure, effectively makes a mound, and that creates midfacial enhancement to complement the lower jaw advancement. What's your to complement the advancement, right? So that you're not too bottom heavy. What's your view on that? When I looked at the morph that Dr. Wallin gave me, I was like, damn, that does look bottom heavy, because I think I'm pretty mid-face deficient. And I was thinking that the cheekbones would be key for me to not look weird. But how do you approach that analysis?
I don't.
Yeah.
I mean, I think, again, my practice is a little bit different. I mean, I've seen, through the course, I saw, Gunson's pre and post, and when he does a lot of cheek implants, and I mean, people look very good cosmetically. But I see the other side of things where you do the advancement, and, I know Alfie, was on your podcast and talked about that by bringing the jaw forward, that kind of helps support things better. Exactly. In all honesty, I don't have a super strong opinion about it. It's not something that I currently kind of do in my practice at this point. But I think there's probably more than one way to skin a cat, so to speak. I think trying to get those, pre and post evaluations and kind of deciding. The benefit is that you can always go back and do it later too. So if you're on the fence about it and you don't do it, of course, there's an extra cost and, operative time and things like that. But, patients, or same with like a genio or something, if patients are like, I don't know if I want that, you can always do an MMA without it and go back later and do a genio if you're like, well, I'd like more support, or if I want cheek implants or things like that.
Yeah, those are all good points. What do you find though? Do you find that graft does provide midfacial enhancement, or is that not the case? I mean, what are you seeing in the befores and afters?
I still think the afters are still, you get better mid-face support with the upper jaw coming forward and kind of grafting this area. Is it as pronounced as cheek implants? No, certainly not. I mean, I think cheek implants are definitely going to be more of a mound than you get from that, but I still think you get much better mid-face support just by advancing, the upper jaw. And part of it depends on how high you cut the Lafort. So like, are you cutting it closer to the zygoma versus lower? So there's probably different nuances to it.
Yeah, and I think maybe part of it is that you do get the midfacial enhancement with the graft, but I think Dr. Gunson is probably going to a completely different location with those implants.
Correct. I mean, his cheek implants are sitting like up high, so they're much higher than where the graft would be. So I mean, you're
probably as opposed to here,
overlying the zygoma rather than packing underneath the zygoma. So it's a different part that he's supporting.
Yeah. So it's a whole different dimension of volume that you're getting.
Correct.
It's a different place. Yeah, that's interesting. Okay, let's talk about the cheekbone area and MARPE. So I would like to load up a slide here for your view.
Sure.
Okay, so this is early in the stages of an ease treatment. I think this is 2 millimeters into an ease with Dr. Casey Lee. And what this GIF has been spread around Reddit to show is that you're getting nasal expansion all the way up the nose, basically all the way up to here, right?
Are you showing something? Because I'm not seeing anything.
Oh, my bad.
Maybe I need
my bad.
Full screen.
Nope, that's my fault. I have to add it to the StreamYard. Perfect. Okay, good catch. So this is showing expansion up the y-axis, so to speak, all the way up here, and then presumably on the z-axis too, deep into the nose at this height, right?
Yep.
And the concern with doing too much of a surgical assist, like to use an extreme example, like a SARPE, where you're straight up cutting through this area, but maybe even with the lateral buttress scoring, which you said occurs right in this area.
Yep.
Right? Is that going to prevent nasal breathing benefits due to this expansion going up the nose? And then as well, is it going to affect cheekbone enhancement that some people are looking to get out of their MARPE?
Yeah, that's a good question. I mean, I think it depends on what you're trying to get out of MARPE. So one of this is kind of the fundamentals of how you think about things. And I think people have different thoughts on it. I think nasal breathing is very, very important, but I'm in the camp that you need more intraoral volume for tongue position as well. And so if you're only looking to expand the nasal cavity, then sure, doing an ease is going to kind of widen the nasal cavity alone, but you're not getting as much intraoral volume. So your molars and your whole palate is not actually expanding as much to create that. So that's where it's kind of like every patient's going to be different. If you have a patient with a deep, with a big crossbite, you need way more intraoral volume. So maybe an ease of expanding 2-3 millimeters is not actually going to be able to fix their crossbite. You need a MARPE, or you need some kind of surgical assist to expand both the nasal cavity and the teeth, if that makes sense.
Yeah, that makes perfect sense. So
I think that to your question, what we don't know is if we don't do that, at least even in my kind of partial lateral buttress cut, is that going to prevent enough expansion? So like, are you going to get 2 or 3 millimeters of expansion? It's going to stop, and you're not going to get your mid-face expansion anyway, if that makes sense. So that's where those are some of the unanswered questions that, at least in my opinion, we don't have great data to support yet. In the ideal world, the less you can do and allow someone to expand, the better. The question is like, are you going to do the minimal first and then they expand, and then, okay, well, their molars didn't expand. So now, now that you finished with a TPD, now you put in a MARPE and you try to get more width of the palate now that the nasal cavity is more expanded, or now are you going back to surgery to do kind of further cuts? Those are the questions that I don't know that we have answers to yet.
Yeah, certainly we don't have answers to those questions. And then you start getting into the thick of it with all the nuances and all the different paths you can take with MARPEs and surgical assists and swapping out expanders, et cetera,
Yep.
layering surgical assists, starting minimal, adding cuts later. And then it's like, well, shit, should I just do a, multi-piece maxillary jaw surgery and just get the widening surgically if doing the advancement? You do both, so you don't really have a dog in the fight. what do you think is just better, and how do you work out this planning with the patient?
Yeah, so I think it really depends on the patient in a lot of different aspects. So some patients don't want to go through a 2-year process of doing a MARPE or a surgical assist with a MARPE, and then a year later doing an MMA. I think the benefit of that is that you get higher up nasal expansion even with the MARPE. And so you can expand, and then maybe you only do a one-piece Lafort. So instead of having to do a multi-piece Lafort, you can bring it forward. There's some data to say whether or not that's more
safer,
less likely to relapse. Yeah, more stable than doing a multi-piece. There's certain people that are doing such high volumes of these that probably it's half a dozen of one and half a dozen of the other in terms of the risk of it. So some people, if they're willing to, then I usually say, hey, why don't we maximize your nasal breathing? Let's maximize the palatal width and volume, and then we'll do the double jaw and bring you forward. In my practice, there's not a ton of patients that are like, especially if they come they come into my clinic from a sleep medicine doc who's like, oh, I don't tolerate CPAP. And then all of a sudden, and they just want to breathe. And I'm like, okay, well, we're going to do 2 years of, a MARPE, which is going to cost you 10 to 15 grand. Then we're going to break your face and move it forward. And they're like, what? I just want to so to the lay person, that's a big deal. And so in some of those patients that either one can't afford to do the MARPE or go through that, or their sleep apnea is so bad that they're like, we just need to fix this now. Those are the patients where we say, okay, let's just do, potentially a multi-piece Lafort, or do your MMA. We'll expand things, as best we can and leave it at that. So it really kind of depends on the patient's tolerance, their resources, and kind of what our end goal is.
Yeah. So then logically speaking, or what I refer to this approach as maximalism, from a purely logical armchair maximalist approach, the most possible nasal breathing benefit that you're going to get is to do a MARPE with minimal surgical assisting so as to get the expansion up the y-axis and down the z-axis, and then do an MMA, which affords its own unique nasal breathing benefits. But the MARPE has certain things it can do that the MMA can do for nasal breathing, and the MMA can do certain things that the MARPE can't do for nasal breathing. And logically speaking, stacking the two of them, MARPE first, followed by jaw surgery, is the best total units of nasal breathing improvement that you could potentially get. Do you agree with that statement?
That would be my opinion. And I totally agree. I think that was well said. I think you can get lateral expansion of the nasal cavity, maybe even of the, which is not, you're not going to get superior expansion with MMA. That's just not the case. But then you get the things like you can lower the floor of the nasal cavity by pulling the maxilla forward. You're pulling the soft palate forward in the back. And so if you think about it, the outlet of the nasal cavity is the nasopharynx in the back of the nose. That whole area in the back of the nose is pulled forward and opened. So you get a much bigger kind of, does that make sense?
Yeah, I'm going to load up an image.
Yeah, perfect. You're pulling that soft palate forward. And so now you have a lot more space behind the nose. So you don't want
a good image. I'm sorry, I did the same thing again. Is this a good image here?
Yeah. So if you're looking at that soft palate, which is, what your uvula and kind of the roof of the mouth is attached to, yes. Right there. When you move the maxilla forward, that whole segment is getting pulled forward, 8-10 millimeters.
I'm sorry, are we looking at this back part of the maxilla here?
So the maxilla is the bone. If you look just to the right of that, so that's the bone of the hard palate maxilla.
And that ends right here.
That ends right there. And this is the soft tissue attached to the maxilla. So if you look farther down, this is the uvula, all the muscles of the soft palate. All of that is attached to the maxilla.
Yeah. And right. That's all this stuff here.
Exactly. Those are the muscles of the soft palate. And so, in traditional ENT surgery, we would do things like a UPPP or pharyngoplasty, where you would cut that, or you try to pull it forward or tighten it. And I still do a fair amount of pharyngoplasties where it's not, where you're cutting stuff out, but you're repositioning. You're trying to pull that muscle kind of forward and out, almost like to give the soft palate a facelift. But essentially what an MMA does is it pulls that soft palate forward. So if you look right above the soft palate, that is the nasopharynx, or the back of the nasal cavity. And that part opens up much more. And so this kind of, the choke point ends up being opened up. So now the nasal cavity is widened with the MARPE, and the back of the nasal cavity is opened more with an MMA.
Right. Wow, man. That sounds like it would feel amazing. I think it's so funny. You describe your typical patient coming in off the street from a local provider, being totally freaked out by like this MARPE. He's splitting my skull in half like a Chinese torture device. And then this MMA surgery, which sounds like, death incarnate, getting my jaws hacked off. Oh my gosh. Whereas my audience is like, oh, please.
Exactly.
That's all I want for Christmas is an MMA.
So that it's funny because I still have a fair number of patients that, either will, follow your podcast or like are much more, they've done their own research. And so, or they come in from, an orthodontist. And when they come in from an orthodontist, they're kind of already have an idea that their jaws are too small if they have dental crowding. So those are the best patients for skeletal surgery that come in already knowing that there's an issue rather than, me in a 20 to 30 minute visit trying to explain to them that, their jaws are too small.
Yeah, but we're kind of a mixed bag too, though, aren't we?
True.
Sometimes we're a little nutty, aren't we?
Yeah, there's a happy medium, I think, that needs to be found. So I think, and that's kind of where, as an ENT, I think the important thing, and we were talking about this offline beforehand, is like, not everything from sleep apnea is also structure related. And so that's a really important thing. It's not all jaw structure related, I should say. So, you were talking about how Dr. Gunson mentioned, potentially getting a DISE or at least getting a scope in the office. I think that's really important because if you do an MMA on someone that has big tonsils or a big lingual tonsils on the back of the tongue or some other kind of soft tissue issue, you're going to have incomplete improvement in that patient. And so some of those patients may need to do some kind of soft tissue surgery first before they do an MMA. So, like in kids, if they have big adenoids and tonsils, if they're obstructing their breathing, do you want to wait for a MARPE to hopefully, maybe improve their lingual tonsil tissue or tonsil tissue in like 5 years? That patient needs immediate resolution of their issue. So you do, maybe a TNA, which is a tonsillectomy and adenoidectomy. And then you think about, okay, now let's do a palate expansion or do some of these other things to fix the structure. And I think the same goes for, skeletal surgery, is making sure that there's not some kind of low hanging fruit that may, one, get faster resolution, or two, now that easier to recover and you might have better outcomes from your MMA if they don't still have redundant extra soft tissue kind of blocking the airway.
Right. Yeah. One interesting thing that I learned during my jaw surgery consult adventure in California with Dr. Bell, Dr. Gunson, and Dr. Wallin, and I will be talking to Dr. Alfie eventually. I didn't realize you did MMAs. Hey, maybe you and I will talk too. But,
right. I don't do cheek implants though. So if you want those, I'm not your guy.
I need cheek implants and I need an orbital box osteotomy to increase my IPD.
Yeah, right.
Someone did that, by the way, with the Turkish surgeon.
I saw some YouTube videos that a colleague of mine sent me and was like, "Is this real?" And that's
real.
Talk about maximally invasive stuff.
Yeah, that's giant implants. He's kind of a legend in the looks-maxing space. Yeah. But what was I going to say? Oh, Dr. Wallin told me I had a big tongue. So just a little bit of background on my case. And of course, I'm not going to let you go without getting a little insight from you on my case. So basically, I have these chronic headaches, right? And they are cervicogenic, specifically sort of in this area.
Okay.
And then they radiate up and forward into my eyebrows, my temples. This has been happening since I was 13, since I completed my childhood round of orthodontics, 8 extractions, braces. Then I played freshman football. I got run over by the star running back. I felt a zing in my neck at that time, and it just has been getting worse ever since. I go to bed feeling great. I wake up with these headaches. The only thing that brings relief to my headaches, and Lord knows I've tried every medical treatment modality that you could think of, including nerve decompression surgeries, my expander, et cetera, and all sorts of medications. The only massage, acupuncture, you name it. The only thing that gives me relief is sticking my tongue out. As interesting as that and as crazy as that might sound. So throughout the day, I'm going about my day like this.
So you're like posturing essentially.
I'm essentially relaxing my tongue, and that's where it falls. It falls forward from between my teeth. And when I told Dr. Wallin this, he's like, that's interesting. Because he's obviously kind of a more conservative guy. He didn't think that I was that recessed, even though I have this obvious airway constriction and, I think I am. Dr. Gunson did, so did Dr. Bell. But he did say, oh, but you have a really big tongue, though, which is to say, maybe it's not just a matter of your jaws being too small. Maybe it's also a matter of your tongue being too big. So and maybe my tongue is going to be wicked gross right now because I had breakfast and haven't scraped my tongue and brushed my teeth. What do you think?
It's a big tongue. I think
it is, right?
Yeah, I mean,
it never occurred to me that it was a big tongue.
Yeah, so I think there's different ways to look at it, and I'd have to look at your imaging to get it a better idea, because there's some thoughts on do people have big tongues or small jaws, and does the tongue seem big because the jaws are smaller, and so it doesn't have enough space to fit. But there are other things. I mean, there's a guy, Rich Schwab, who's a really well-known sleep medicine provider at Penn that I worked with, who is basically doing a bunch of MRI type research, and they looked a lot on fat deposition and kind of size of the tongue in OSA sleep apnea patients, and whether or not there's some component of excess kind of soft tissue and fat. So there's actually a whole new there's a brand new company called Cryosa, interestingly, that is looking at kind of cryoablation or freezing the tongue fat. So it's currently in clinical trials, but they're looking at do certain patients have excess fat in the tongue, or for whatever reason excess musculature, or has your tongue become more muscular because you're posturing all the time, like you're like working out your tongue nonstop to try to get more comfortable. So it's hard to know without having some of that other data, or seeing MRI imaging. Do you have more tongue fat? Is it just a larger tongue? Is it that the jaws are a little bit too small for the size of the tongue? But there are a lot of patients that feel that either the tongue, or they need to posture their lower jaw because they feel like either the lower jaw is set back or their airway is too small. And by posturing the tongue or the jaw, they feel more comfortable and relaxed by keeping the airway open.
Yeah, that's interesting. What do you think about patients like me who present primarily with cervicogenic headaches? Do you think there's a relationship between jaw structure, airway health, and headaches? Have you seen that a lot? Are you seeing neck posture improve with MMAs or with other things that you do to open up the airway and relieve the tongue? And so I'll let you answer that, and then I want to ask you a little bit more granular of a question about looking at an issue like mine, which is neck pain, not strictly from an airway perspective, but from a neuromuscular perspective, where my working hypothesis is that what's going on is that keeping my tongue inside of my mouth is causing an overuse of muscles in the back of my neck somehow. I don't know if there's a connection between the tongue and the muscles at the back of the neck. I've asked so many different doctors this. No one can really give me a straight answer on that. But when I flop my tongue forward, I feel a release of muscles at the back of my neck, right where my headaches happen. So I think that's what's going on. I think my jaws are too small, or my tongue is too big, or a little bit of both. And then holding my tongue in my mouth is causing an overuse of muscles at the back of my neck, which is then causing compression of nerves that run through those muscles that then get irritated, compressed, and pissed off, and then flare up into a headache episode.
Yeah. So I think, going back to posture, I do see that posture often improves post-MMA. And I think you'll see a lot of patients that, they have this forward neck posture. So their head is leaning forward, and it's because they need to rotate their lower jaw forward to try to help keep their airway open. Because if they actually have good posture, their airway is too constricted and it's not comfortable. So you just naturally, learn to posture. And I think, Gunson talked a lot about this in his course. I think he sees it or maybe recognizes it pretty frequently, that a lot of people that have migraine headaches or cervicogenic headaches, that if you have constant posture, you are really tensing a lot of the muscles that are kind of holding that neck forward and getting a lot of pain in the posterior neck muscles. And so whether or not, I don't have a great answer for, why keeping the tongue for you in particular, but certainly if your airway feels restricted, perhaps there's posture issues or other things that are going on, that you're activating these posterior muscles more. because it's sensing kind of that restriction or tightness where that relaxes once the airway feels more open.
That's super interesting. Do you think these muscular compensations around head posture occur in sleep as well? And that like they could be worse during REM, let's say, where like I don't know what would be going on, but presumably we're doing these things at night too, not just when we're awake, right?
Yeah, no, I mean, I certainly see, and I've had patients, talk in pretty vivid detail about like when they sleep, especially when they're retrognathic, they have to kind of posture their neck in a certain way to kind of hold it forward, to sleep like this. Because if they try to sleep with a perfectly straight neck, it's the same thing when they're awake. They feel like their airway is restricted. So I certainly think, that goes with sleep too, that you're kind of holding your neck in a certain position all night to try to maintain patency. And that can also kind of, potentially long-term wreak havoc on the musculature and the cervical spine and whether or not that's playing a role. I don't know. It's a good question about, whether or not during REM, there's any further changes to that. But I think, people that wake up and they have a stiff neck or, is that because they were sleeping in a certain position where they were posturing all night?
Yeah. I think at least part of the contribution of the REM is that when you have the disturbances or when you have the oxygen drops, that's adding additional kind of inflammatory fight or flight activity inside of the body that can maybe contribute to muscular tension, and maybe the whole thing just puts you over the edge to where the muscles start to like flare up, and it's just kind of a perfect storm of contributing irritants or stressors to the neck. Yeah, well, thank you for your opinion on that. One thing is for sure, all three surgeons who I spoke to said that they do not treat headaches, and that they are looking at me as jaw surgeons, not as someone who treats headaches, and they certainly cannot guarantee that the surgery will have any positive impact on my headaches.
Yeah, and I think that's a safe way to do it, because there's so many factors that cause headaches, right? I mean, there's so many different neurologic, muscle tension, other things that just moving the jaws forward is not guaranteed to fix. It sounds like from what I've heard, there are people that can have improvement in some of the headaches that are related to the cervicogenic pain, but that's certainly not a good reason to pursue an MMA if that's your primary goal, because it's an unpredictable outcome. Your airway is certainly going to be better, but is that going to fix these other issues? And it's, may or may not be completely unrelated.
Yeah. No, that's for sure. It would be a leap of faith no matter what.
Yeah.
I would like to pivot to nasal surgeries, turbinate reductions in particular. Are you bullish or bearish on turbinate reductions? What do you think about empty nose syndrome? How do you do a turbinate reduction to prevent someone from getting empty nose syndrome? Is the whole empty nose syndrome thing way overdone? Is it the boogeyman?
That's a good question. I think, I still do turbinates on almost everybody. I am definitely more conservative with turbinate reductions on these patients. So, the way I do them is basically making a little incision right on the head of the turbinate, which the turbinates are these long sausage-like structures that run from the front to the back of the nose. I don't know if you want to pull up a picture on, but
I'm gonna.
I make a little incision just on the front of that kind of hot dog turbinate. And I personally will slide in a really small, what's called microdebrider. I call it a mini Pac-Man. And so it's just a long, thin rod that at the end of it, it can kind of chew up some of the tissue on the inside. So yeah, exactly. So if you look at, say, the picture that has the enlarged turbinate, yeah, that works too.
This one?
The one on the second from the left, upper left.
Yes.
Where you're looking. Yep. So I make an incision right on the very front of the turbinate, and in the very
here front, or here,
right in the mid portion of it.
Okay.
And just kind of slide this instrument in. That just kind of takes the air out of the balloon. So I'm not cutting out any of the mucosa, any of kind of the nerve endings on the outside that sense airflow. You're just kind of decreasing volume. And then a lot of people, and I do this as well, do what's called an out fracture. So there's a little bone that holds the turbinate, and you just kind of fracture the bone out to the side. So you just kind of take it and you just push it to the side to allow for more space for airflow.
Would that be here at this stem? So are you bending it at the stem, kind of?
It kind of goes down like halfway of the turbinate. So it goes from the stem and kind of hangs down like this. I don't know if there's a. Let's see if there's a good. So if you look at the one on the like fifth from the right, the CT scan, that's the coronal view. It's nasal anatomy, sinus health. Yep, right there. So if you blow that up, you can see really faintly there's the white bone that's in there. So some people have that bone right there. Some people have a really thick bone.
This little faint white bone here,
and it kind of usually it goes another kind of couple millimeters down towards the middle of the turbinate.
Mm-hmm.
So it comes down there. So you can take that bone and just kind of fracture it out so that it gets pushed farther outwards.
So you're kind of bending it or fracturing it so that the turbinate is now.
So instead of like this, the turbinate sitting like this, you just kind of push it out like this. So that the whole turbinate is still there. It's just you have a larger space for the air to flow.
But then wouldn't you be compressing this part of the airway?
Yeah. Well, so the majority of airflow, based on some of the studies, really comes above the inferior turbinate, right at the level of what's called the middle turbinate. So it'll actually come in and go above the turbinate, and right where that star is, right below the star, that is kind of where a lot of the maximal airflow comes. And so you're just kind of pushing it down and out. So there's not a ton of airflow that's going to come laterally that you're obstructing. It typically will flow up, over, and then to the back of the nose.
So once you fracture it, how do you hold it in that sort of tucked in position?
So usually after I do a surgery, I'll put splints in the nose. So I'll use these things called Doyle splints. So these big kind of plastic tubes that run from the front to the back of the nose, and they just kind of hold the septum straight and they push the turbinate. So it's almost like just if you type in Doyle splints nose, yeah. So that's what they look like. So the outer kind of circle, kind of the half circle, presses up against the turbinate and just kind of holds pressure as it's healing. So
wow.
it helps reduce swelling. They're not super pleasant, so I usually only keep them in for like 4 or 5 days. And then you just slide them out in the office. But that kind of reduces that's a little bit different, those types of splints. But it just helps kind of reduce swelling, and it also helps that bone just kind of stay in that position for a couple of days.
Wow. So you're not doing ablation, radio ablation of the turbinates?
I don't. Yeah. So, I mean, some people do. I just use the microdebrider and kind of do a minimally invasive way to kind of reduce that tissue. In practice, I think empty nose syndrome is a little bit overblown. I think we certainly see it in some patients, but I think it was more common when people were much more aggressive with the turbinate. So like back when sinus surgery started, if you look at microdebrider, microdebrider is the. Yep. So it's basically just like a tiny little rod that can be inserted into the turbinate and just kind of
it chips away at it.
Yeah, it kind of eats up the tissue from the inside out like a little mini Pac-Man. So you just kind of reduce a little bit of the soft tissue under. And this is obviously most of the time I do this while they're asleep. So they're under general anesthesia because I'm doing, a septoplasty or something else. So that again is on the inside typically. So we're not like cutting out any of the outer tissue of it.
So you're penetrating the turbinate and then you're
exactly. So you actually
debriding the inside
into the turbinate, and you're completely surrounded by the turbinate. And then you're just kind of like chewing a little bit of the tissue so it kind of shrinks down, and then you take it out. So the outer area that senses airflow, the nerve endings, the mucosa, that is all left intact. You're just kind of shrinking it down a little bit.
Okay, because I think when people think of debriding, they probably think that you're just gnawing away at the outside of it, and they're like, oh, well, that doesn't sound like it's going to maintain the sensory nerves.
Yep, so it's just from the inside. So you're basically, sticking a straw into a hot dog and kind of, deflating the balloon just a little bit.
Right. Wow. That's genius.
So yeah, I think that works pretty well. I've, in the, 5 years that I've been in practice now, I've never had a patient come back and have any symptoms of empty nose syndrome with that. I think when sinus surgery started, people used to be a lot more aggressive, and you would completely cut out the inferior turbinate, or if you remove a lot of the outside of the turbinate, there can be a risk that you kind of over reduce things. But in general, at least I have not seen it in practice, and maybe that's because I'm doing things a little bit more conservatively. But I have plenty of patients that they're like, I don't want you to touch my turbinates. Like they're like deathly afraid of empty nose syndrome. And I think that, in my opinion, is a little bit like the boogeyman. Like it's that I wouldn't be kind of as deathly afraid unless your surgeon's like, I'm just going to, whack out your turbinate, which not many people do that anymore.
Yeah. That's like, it's not a nuanced enough perspective. It's
Correct.
It's like taking a blanket thing and saying, hey, I will never do anything like this.
Exactly.
Because of some fear that comes from a specific way of doing that.
Correct. And I would say, I mean, if you look at patients that are not using their nose, their turbinates get more swollen. So, if you have someone chronically mouth breathing, if you figure out how to convert them to nasal breathing via surgery or MARPE or whatever that might be, and they start breathing through their nose more, the more you breathe through your nose, the less swollen the tissue gets. The less you breathe through your nose, the more swollen the tissue gets. So like I have a ton of sleep apnea patients that are like, oh, I wake up in the morning and I'm so stuffy, I'm so congested. And a lot of those patients, it's because they're mouth breathing all night. So if you're not using the nose, it's going to get more and more swollen until you wake up. They're congested, they blow their nose, they're up and moving around. Gravity helps kind of decrease the swelling. And then they're like, during the day, I breathe through my nose fine. It's just I wake up in the morning every morning congested. And a lot of times that can be because they probably were not optimally using their nose while they were sleeping.
Right. That makes perfect sense. If you don't use it, you lose it.
Yeah.
Do you like to try a MARPE before a turbinate reduction, or do you like to always pair a MARPE with a turbinate reduction? Dr. Anil Rama, a fellow sleep medicine specialist, said that if you don't do a turbinate reduction, or what he says, if you don't manage the turbinates, they will just expand to occupy the new space that you've given to them with the MARPE. Do you find that to be the case?
No. So I think if you are breathing, okay, there's a nuanced question with that, because just because you're breathing through your nose, there are also a lot of other causes of turbinate swelling. So, if you have a dust allergy, if you have environmental allergies, you can breathe through your nose all the time, but you're going to have some inflammatory reaction causing the turbinates to swell. So even after MARPE, there are patients that I need to keep on sprays like Flonase or azolastine, which is an antihistamine spray, to prevent them from reswelling. So I think, it's very patient specific. I think if, there's certain patients that, again, my practice is a little bit more unique because I have all comers coming into my office. And so, even though I would recommend MARPE in probably, 50% of my patients, the reality is 5% of them may actually end up pursuing that for financial reasons or, others. So a lot of those patients, I'll say, hey, ideally we would expand things because, again, the size of the room is too small. But a lot of times I end up doing like a septoplasty and a turbinate reduction because they're like, well, I can't afford to go through a MARPE, or I don't want to have a year-long process, or, they just finished up Invisalign from some dentist that kind of maybe missed the fact that their airway was too narrow to begin with, and maybe they should have done a MARPE. So I think it's really patient specific. But a lot of those patients I'll reevaluate after MARPE. So like 2 weeks from now, I'm doing a septoplasty and turbinate reduction on a patient that finished MARPE, had really significant improvement in nasal breathing, but it's still restricted because she has a bad deviated septum. So I said, let's expand, let's see how you feel. She's better, but like not all the way there. So now we're going to go back in and fix the septum and shrink down the turbinates a little bit.
Yeah. Thank you for that nuanced perspective. Yeah, definitely it's patient specific. What is the deal with allergies? Like, why are humans so sensitive to things that are in the environment that can just destroy their health? Or is the allergy thing overblown? I mean, do you recommend allergy testing for most of your patients?
Yeah.
Why are we so allergic to stuff?
I do not have a great answer to that. I mean, I'm certainly not an expert, but I think how much of it is environmental and what we're putting in our food, putting in the environment with all these microplastics, with all these processed foods and other things like that. It's hard to know. Things like, I heard you guys talking with Mew, I think, on one of the recent podcasts, where like you're sealing the houses so completely that like your kids are inhaling dust or you're inhaling dust all the time. And so we're doing things that we never used to do for like, economy of heat and all these other things that is causing there to be much more of a buildup of dust and all these other things. So whether or not, some of the jaw underdevelopment type stuff is like, is it because kids develop these allergies and start mouth breathing early? Or is it, the breastfeeding, or is it transitioning to soft foods rather than solid? There's all these different theories, of why that happens. But I do see a lot of patients so I don't test allergies in everybody, but usually if you have significant nasal congestion, we want to rule that out as something to say, okay, well, this is clearly an inciting factor. Maybe we should consider involving the allergist as part of the treatment plan to say, do you need, immunotherapy like allergy shots to try to desensitize you? Or do you need kind of the newer thing is sublingual therapy, where the allergist can create either, liquid drops or tabs where you can just put it under your tongue instead of having allergy shots to try to desensitize you to certain things.
It's almost like a vaccine for allergies.
Kind of, yeah. I mean, the goal being to kind of slowly build up your tolerance to the allergies over time, so you stop responding to them.
Yeah, Dr. Mew said in my interview with him that just living indoors in and of itself is unnatural, and that he said it's the main contributor to like essentially facial underdevelopment due to loss of function of the nose at an early age. So it's who knows? It's an interesting perspective.
Yeah, there may be something to be said about that. Whether or not they're, why are so many babies converting so early on to mouth breathing? I've seen that in my own kids where, early on they are nasal breathing, and now they're getting older, and I'm keep like, shut your mouth, keep your mouth closed and breathe through your nose. And I'm constantly reminding, but it's hard to know what certain aspects are causing some of these issues.
I think that's such a critical question. I'm having the same experience with my daughter. She just turned 1 yesterday.
Congrats. Happy birthday.
Thank you. And you have some kids then?
Yeah, I have a 3 and a 5-year-old.
Oh, that's awesome. That's great. Yep. God bless.
Yeah, fun.
Has it been frustrating for you trying to keep them on track to like proper facial development? I know it has been for me.
Yeah, I mean, it's a good question. I mean, even with my daughter, we tried to do at age 4 already a palate expander. So just like a tooth-borne expander with one of my colleagues in Chicago that does pediatric expansion. And it's hard to know.
Wasn't Courtney Donko, was it?
It was, yeah.
Oh, nice.
Yeah, Dr. Donko is a good friend and colleague. So she was the one that did my daughter's expansion, but we're already looking at like whether or not she needs another round of it a year later. Like it expanded somewhat, but like she's still mouth breathing a lot. She's still kind of retrognathic. So there's different things of like, what can you do? And, there's different things like she's a super picky eater. And, there's been some claims that, not necessarily well researched, but is that because her chewing or other things are causing her to be a picky eater, or is she a picky eater because she's a picky eater? But it's unfortunately because of the world I live in, I kind of obsess over it a little bit. So like I'll sneak into my kids' rooms, and if they're mouth breathing, I'll like gently bring their lips together to make sure they're breathing through their nose when they're sleeping. And haven't gone as far as taping their lips closed, because I think my wife would kill me if I went in and was taping my kids' mouths closed. But yeah, I mean, it's certainly something that we're searching for. And I think, you can expand, but if you're not changing the function, that's a problem. And so that's where the question is, of things like myofunctional therapy or things like that, which is still a little bit like the Wild West. I think there's some good data that's been published out of places like Brazil and Spain that have very rigorous myofunctional, therapy type things. But, whether or not there's, just because you expand doesn't mean they're going to all of a sudden start using their nose, or they're going to start maybe chewing the right way or doing all these other things. So what can you do after you change the form to like help improve some of these functions to promote growth? And I know, I'm certainly not an expert on the pediatric side of things, but those are things that I think about frequently.
Yeah. I can just share an experience that we've had, which is that my wife wanted to breastfeed as much as possible, being, the JawHacks wife, right? Like she,
didn't want to feel judged.
Right. But also she believes in it, right? And she, she believed in it, and she wanted to have the experience. But at around 9.5 months, the baby started getting teeth and started biting her. And I'm not talking like annoying little bites. I'm talking like I would hear screams of death from across the house. Drawing blood.
Yeah.
Right. And at that point, it was just like, plus she's pregnant again. And
congrats.
Thank you. Due in March. So all of these things coincided to she stopped breastfeeding at around 10 months.
Okay.
And as soon as she stopped breastfeeding, that's when I started noticing the baby start converting into a consistent mouth breather more often, right?
Yeah.
So my working theory is that you can't really reason with the child under the age of, let's say, 2 or 3, especially one, they're not even verbal. You can't instruct them to close their mouths. Breastfeeding is like it's the original myofunctional therapy. It like you literally can't get the food into your belly if you're not sealing your mouth and breathing through your nose, because the liquid's not just falling into your mouth, you're having to work for it. And that's stimulating your palate and forcing you to breathe through your nose. Whereas with a bottle, you can kind of like, kind of cheat. So my working theory is that it really is all about the breastfeeding when it comes to nasal breathing at that age. What are your thoughts on that?
Yeah, I mean, again, I'm certainly not an expert, but I think that it's so multifactorial. So, I mean, is the breastfeeding promoting, but then there's also, is there some kind of allergic component going on, or dust or other things that's causing, more nasal congestion? But I don't have a great answer to that other than it's so common. And, a lot of people, in general, obviously your podcast viewers are different, but like, a huge part of my practice is thin or normal weight patients. So like, a lot of people think in the general lay public, like sleep apnea is a disease of overweight people, but all these people are people that have underdevelopment of their jaws. Either, when I see a patient under 40 that's of normal weight that has sleep apnea, it's almost universal that they either have narrow jaws, setback jaws, or they have big tonsil tissue, or, maybe the theory is they have big tonsils because they have small jaws. So now you have a double whammy where the room is smaller, plus you have, a big sectional couch that's taken up, half the room. So I definitely think that these patients end up growing up, and that's why we're seeing such an epidemic of sleep apnea and kind of sleep disordered breathing, is all of the kind of underdevelopment. So I think a lot of the focus is, especially in the dental community, is like, how can we intervene early and change it? I don't think everybody needs a palate expander, but are there certain things that we can do to kind of promote growth so that if kids' jaws develop normally, they won't be in our position 30, 50, 60 years from now.
Yeah. And I guess kind of what I'm saying is that there really is no intervention that's going to be able to be as elegant and effective as breastfeeding. Yeah. And that sucks, because breastfeeding is hard and it's just not possible for a lot of people. And so that's kind of where my mind is going is, how can we invent something that replaces breastfeeding, that allows more breastfeeding, like motion for the child, in households where breastfeeding is not actually possible. Yeah. And I'm thinking of like a breastfeeding device that
it's like, I think they already did that in Meet the Fockers, right?
Meet the Parents.
Big breast that you can wear.
Yeah, Meet the Parents.
Or was it
I know.
Meet the Parents? I thought it was the sequel. Maybe it was
Maybe it was. Maybe it was Meet the
sequel.
Okay. Yeah, right.
Yeah.
But exactly. Which it's sad that we think of it in those terms as like a comedic kind of prop, but I just don't see any other way of really forcing a child to be a nasal breather.
I don't have a good answer to that, but I think that's definitely an area that needs to be researched and kind of sorted out better.
If we can get to the moon in 1969, then we can invent something that allows babies to get breastfeeding like stimulus, right?
Yeah, you would think so. Or formulate bottle nipples or these other things that it's going to be more, accurate to that. I certainly can't imagine that there's not, something out there that can be redesigned or better designed.
Yeah, I'll work on it. All right.
Perfect.
Get back to you on that. A question that I forgot to ask you: what's the relationship between MARPE asymmetry and MARPE surgical assisting? Does surgical assist help prevent asymmetries, or is your understanding that asymmetry is caused by things not related to the resistance forces from the skull?
Yeah, that is a really good question. I think it can be both. I mean, I've seen MARPE asymmetries non-surgical, and I've seen MARPE asymmetries surgically, where if you release the pterygoids more on one side versus the other, is it still being held in place, or if you don't kind of fully separate the buttress, or depending on how you're doing things, or is just the bone thicker in one part? So like, the parts that are still intact in that patient, is it stronger on one side? Because the problem with MARPEs is that it just pushes apart from itself. So it's just giving equal pressure to both sides no matter what. And if one side expands more, the MARPE is just going to keep pushing the one side to expand more.
Yeah.
And that's where
MARPE's dumb.
Yeah, exactly. I mean, you can't control the vector of force. It's just pushing apart. And I think that's one of the downsides for both surgical and non-surgical is, other than doing an MMA and a multi-piece where you can put the segments wherever you want, as soon as you start seeing asymmetry, the more you expand, at least in my experience, the more asymmetric it's going to get. So like it's already too late. So if you keep turning it, you're just going to have one side keep expanding more. And so the thought is, okay, take what you get, and stop there and either fix the rest orthodontically, or, if you're planning on doing a second stage, it can be corrected at that time. If you're doing a second stage MMA with like a multi-piece LaForte, it can be corrected.
Yeah, that's right. Are you considering an MMA surgery at all for yourself?
That's a good question. Am I considering it, or would my wife let me? Because those are two very different.
That's my problem too.
Yeah,
my wife doesn't want me to. She really won't let me.
I certainly. It's interesting because my own path, and I don't know how I ended up in sleep apnea, because it happened to be totally unrelated. But like now I'm like the same phenotype as so many of these patients, where like I played volleyball in college, and like I would get horrible neck spasms where like I would turn my head in a certain way and all of a sudden one side would completely seize up, and I would have to have our trainer work for like hours, like digging in and trying to like loosen it up, or like wear heating packs on one side. And I think a big part of that was posturing. Like I kind of have my neck forward because I have retrognathia. I had narrow palate. I also have some retrognathia, and I certainly could benefit from a jaw surgery.
I caught your side profile. That's why I asked.
What's that?
I caught your side profile a few times during the chat.
Yeah, no, exactly. So I've personally, sorry, my dog's scratching on the door outside.
It's all good.
So, I've thought certainly that would improve things, and I still probably am on the spectrum a little bit of like UARS or kind of unrefreshing sleep, but having two small kids and a busy job certainly doesn't help my sleep quality either. But it's crossed my mind.
Yeah. Okay. And so if you were to get serious about it and all of a sudden you're like, hey, you know what? Like I have a window, the kids are now all at school every day, and, I have this opportunity to take this short sabbatical. How would you go about planning your own jaw surgery? Who would you see? How many surgeons would you see? What would you be looking for in order to get a consensus on what would be appropriate surgical movements for you? What's your thought process on all that? What advice would you give to other patients who are considering a jaw surgery?
Even patients that come to see me that I'm recommending jaw surgery, I never recommend against a second opinion. So I don't think it hurts to see, 2 or 3 people, or some people obviously, if you start getting up to the 10, then you're kind of probably searching for something that doesn't exist.
Yeah.
Or you're not kind of mentally ready for it, in my opinion. But, I would probably look at my own CBCT, look at my own kind of pictures, front, side, all these different things, and kind of look at my own, how I would plan my own surgery, and then probably go see a couple different surgeons like Gunson and some other folks to get their opinions on, is it similar to what they would do, or kind of what their thoughts on recommending something like that would be.
Yeah. No DIY jaw surgery, right?
Not yet. I didn't put the MARPE in myself. Maybe I should have considered it with like a little mirror or something like that. But I think I would probably pre-plan things and figure out where I think things should go. But then obviously I would want to get opinions from the people that I would be seeking something like that out. And I think it's interesting to get different opinions, because it's, everyone says, oh, it should be like it's a science, not an art, but jaw surgery, there is a big artistic component to it. So I think, maximizing the advancement while still kind of maintaining cosmesis and how you're kind of improving airway versus the cosmetic nature of things and all that.
Yeah. There's all the movements that the surgeons offered to me were quite similar.
Yeah.
And yet all 3 treatment plans that I was given were all very different too.
Yeah.
Like Gunson wants me to do some very specific orthodontic work and restorative dentistry, and some, certain diagnostics before he'll do the jaw surgery. And then Dr. Wallin is more like, I like to keep it simple. I don't want to add a restorative dentist and another orthodontist into the mix. I want to keep it simple for you. Let's just do this. And then, Dr. Bell is like, well, it's up to you. Can you tolerate more orthodontics, or do you want to take a more streamlined approach? We can do it sort of all these different ways. There's no one way up this mountain. And it's like, yeah, I didn't realize that there was so many different ways of going about it. But there are.
Yeah, there's a lot of nuances with both pre and post-op care and kind of preoperative planning. And I don't know that there's any one, perfect answer. I mean, I think, some people would say, okay, well, if you're going to line up everything perfectly with orthodontics and restorative dentistry and having every teeth in the perfect place, is that going to optimize your outcome? And hard to know. I think certainly the more attention to detail you have is better. But I think there's so many different ways you can go. And is your airway going to be just as good no matter what? Probably. If there's similar movements, the airway result is probably going to be the same. It's just some of these other things that are a little bit more nuanced.
Yeah, right. I mean, I'm an aim small, miss small guy where like, let's really hone in on the fractions of a millimeter here in my teeth to make sure that we get, the optimal surgical outcome, right? But I'm also been in orthodontics for over 8 years and I'm totally freaking burnt out. So it's like, but I think that's dangerous because I don't want to make a lazy decision when it comes to the most consequential 100%. Treatment, right?
Yeah, no, I mean, that's a big thing to consider is like if you're going to invest this much time and energy in recovery, like you want to make sure it's done the right way. And that's a lot of patients. There are patients that, again, in my practice, that are like, oh, I don't want to do ortho. I'm like, hey, this is a big surgery that we need to do the right way. And we need to kind of make sure your teeth are lined up and we're not just going into something and, sure, your airway is going to be open, but now your bite is off. And is that going to contribute to TMJ dysfunction down the road? And, or condylar resorption because your teeth are hitting incorrectly because we didn't line things up. So I think, there's different ways to look at it. If you're really going in and your AHI is 80, we need to get you corrected. We can't put you in 2 years of orthodontics to do that. So we kind of do our best. So it depends on what you're going into it to resolve and how severely symptomatic the patient is.
Yeah, no doubt. Have you thought about things that you would do to optimize your recovery if you were to do a jaw surgery? Things like hyperbaric oxygen or fasting or supplements? Or any thoughts on how to like really get a great bang for your buck out of your recovery?
Yeah, I mean, I think there's a lot of different things you look at, and I know Gunson, like in his course, talks a lot about some different preoperative vitamins, and depending if there's any condylar, issues or jaw joint things, putting people on things pre-op. I think optimizing vitamin D and calcium, things like that are going to promote bony healing and make sure that your bones are kind of as solid as they can be, especially for a white guy in the Midwest where, now it's winter and you're going to, not be getting much vitamin D out there. I think there's different things out there. I mean, I can't say I've dived into this deep enough on my own to think about it, but, making sure you have an adequate food processor where you can really, I have patients where they're like, oh, I stocked up on Ensure for post-op. And I'm like, don't do that. Like you're going to get I had one guy drop 30 pounds because he got so sick of Ensure every day that he just like didn't want to eat it anymore. And so then he was like starving.
Wow.
Like there's so many good things out there. There's an old school like jaw surgery cookbook. There's so many resources online that you can find for liquids or soft foods. Having things there are different like coolant systems where you can kind of like put a face wrap on that kind of circulates cold, that some people have talked about to really maximize icing within the first week or two afterwards, because a lot of patients, that's their biggest complaint is that people can get, fairly swollen after surgeries. So, doing things like that to kind of help make the post-op process a little bit easier.
Yeah. And last question, I know you got to go here, but from a spiritual perspective, I mean, you're dropping maxillas and fracturing mandibles on other people and you see like what that involves. How do you cope with the physical trauma of jaw surgery when you're considering it for yourself? Like, how do you spiritually come to terms with a surgery like that, and what it would feel like to wake up from a surgery like that?
That's deep. I can't say again that I've gotten close enough to really, look into that. But I think it's a big thing because I know too much in terms of everything involved in that kind of surgery and the healing period, and having everything not wired but at least elastic. I use elastics post-operatively to maintain their bite. So having teeth and elastics for a couple of weeks after the surgery, it would be a lot of meditation beforehand and kind of mentally preparing, and probably more mentally and preparing and apologizing to my wife, because she's the one that's going to be dealing with me, complaining for the next 2 to 4 weeks after the surgery.
Yeah. Would you want your wife to see you swollen like that? You wouldn't, right? I would want my mom to be with me instead.
She was married to me with an 8 millimeter diastema gap in my teeth. So she's a good woman.
That's fair.
Yeah,
that's fair.
But no, I think she would do fine. I think my kids would have I would not want them to see me kind of immediately post-op until the swelling kind of came down. So that would be, but I know they would want to see me. So that would be kind of the hardest part, probably, is not coming out looking all puffy and my 3-year-old son being like, "What happened to you?"
Totally. No, I think that's a scary thought too, is what would my kids think when they saw me swollen like a balloon? Yeah, you'd want to just be on a beach in Santa Barbara, right?
Yeah, right. Exactly. I think the last thing to touch on too, I know we had talked about this ahead of time, things like Inspire. I don't know if
yeah, sure.
You wanted to kind of touch on that. So I think, ENTs in general, I think the knock that we sometimes get is like, now that this Inspire device came out, which is like a pacemaker for the tongue, essentially is what it does. So there's a pacemaker that gets implanted in the chest. There's a little incision under the chin where you find the hypoglossal nerve. If you type it in, you'll find some good photos for the audience.
Yeah, I'm going to load up some images here.
So I think, a lot of ENTs, kind of the practice for sleep apnea is either kind of a pharyngoplasty or like soft tissue surgery or Inspire, which again, I think sometimes we kind of can sometimes miss the big picture. But I do think the warning, to the audience too, is that exactly. Yep. So usually there's like a little sensor that goes between the ribs. So you can see that, exactly. That kind of senses breathing. There's an IPG or pacemaker type device. And then there's a little wire that gets attached to the hypoglossal nerve that when you turn it on at nighttime, kind of every time it senses a breath, it'll stimulate the muscle of the tongue to move forward. So you fall asleep, and when it kicks on, every time you breathe, the tongue moves forward and then relaxes, moves forward and then relaxes.
Is this unit surgically implanted? That's underneath the skin?
Correct. Yeah, that sits on the pec muscle. So there's an incision over the chest where that whole unit, so it's comes from pacemaker technology.
Oh.
So that gets implanted, sits under the skin, and then all of these wires are under the skin. So there's nothing exposed in terms of the wires or anything like that. It all runs under the skin. I think it can be a great option in the right patients. And I think that the important thing to know is, there's a lot of different causes of sleep apnea, and anatomy is only one of them. And so you think about jaw structure, really important thing. Almost all of us are skeletally deficient. And so that's an important component. But there was a study, there's a group of kind of respiratory physiologists at Harvard, Boston, or Mass Eye and Ear that has published a lot of work on these different kind of phenotypes, it's called, of sleep apnea, where, it's not just anatomy, there's muscle tone that comes into it. And so one of the thoughts maybe is that, if your jaws are underdeveloped for long enough, the muscle kind of just burns out, your tone burns out, so that when you're older, all of a sudden, even if you do an MMA, the tongue is still falling backwards or the muscle is still collapsing. And so things like this can help improve the muscle tone, especially in older patients. So, probably average age is like 65 for patients that get this Inspire. So it's a pretty non-invasive, hour outpatient surgery to do that. But then there's things like something called loop gain, where it's a very obscure thing, but it's essentially ventilatory instability, where your breathing stops, your carbon dioxide levels kind of rise, and then all of a sudden you breathe a bunch and your carbon dioxide gets too low, and then you stop breathing and then it rises, and you just kind of keep over and undershooting. That's more common in like cardiac patients. And then there's some things like arousal threshold. And arousal threshold is what we think about like light sleepers. And so if you have a low arousal threshold, even small changes in breathing are going to cause these micro arousals where your brain is getting woken up out of sleep. And so a lot of these patients, we think, maybe the UARS spectrum, some of those patients also have a low arousal threshold where, it's not bad enough to be classified as sleep apnea, but the breathing is deficient enough that causes all these disruptions from sleep. And so you wake up fatigued and you have all these symptoms of sleep apnea without, desaturations or drops in oxygen level. And the group at Mass Eye and Ear basically published that most sleep apnea patients, I think it was, I can't remember the exact quote, but it was almost like 50% have at least two of these phenotypes. So like anatomy may be one, but they're also deficient in muscle tone or arousal threshold or other things. So, just doing a jaw surgery on every single patient with sleep apnea is kind of missing the point and trying to figure out my job is trying to figure out what are the interventions we have. And like after a DISE, after a sleep endoscopy, I'll be like, okay, well, again, I have a different population that's not only coming to me for jaw surgery, but it's like, we can do Inspire, we can do a pharyngoplasty, we can do an MMA, are three different ways that we can go, and then let patients decide based on kind of, some people are like, I want the least invasive or shortest recovery, or I don't want you to, do any kind of bony work. So I think there's different ways to treat sleep apnea. And I think the important thing again is that it's not all a size of the room problem. I think that's an important part of it, but there are all these other nuances that cause sleep apnea. And it's important to kind of keep that in mind.
Could you see Inspire being even a complement to a jaw surgery? Like after a jaw surgery, 6 months later, you're still, tongue's still falling back. You throw the Inspire in and then boom, you have.
So what's really interesting? I had a patient who got Inspire about 5 years ago. He was, I think, in his late 40s now and did not work for him. So, he got it from an outside guy, comes in to see me, and I'm like, you're super skeletally deficient. I mean, bimax deficiency, upper and lower jaws are set back. Whole airway is really small. I put him to sleep and did a DISE with the Inspire on. Everything's just totally collapsing. He's still stopping breathing like 45, 50 times an hour with the Inspire. And so we ended up doing an MMA on him. So, I'm like, hey, let's leave the Inspire in because we don't need to take it out yet. Let's do your MMA. The MMA, I think we brought him from like 70 to 28. So, he had significant improvement, but like not technically a surgical success because he still has moderate sleep apnea. Once he, recovered from that, we were able to turn the Inspire way down because now his airway is way more open. And now he's using the Inspire every night after the MMA. And now his residual AHI is like 10.
Wow.
So that's one where like, I think, and Stanley Liu, when I talked to him a couple of years back, there's certain patients that like probably need multiple interventions where, the MMA can get you so far, but especially if you're older, if you've had skeletal deficiencies your whole life, like an MMA may not be enough to change the muscle tension in the airway. Like your muscles are too old to kind of retrain and tighten, even though the jaws are forward. And so they need multiple interventions.
Yeah, that makes sense. So it's like the bone structure may be the root cause of why all the soft tissue is all out of whack, but just fixing the bone structure doesn't mean that the soft tissue is going to follow suit automatically. There may be extra work or extra intervention needed to kind of pick up the slack on the soft tissue because of a lifetime of atrophy and poor function.
Exactly. And I mean, I think that's where some people are like, okay, the earlier you do an MMA, the better, because then their airway, if you do an MMA in a 20-year-old, their muscles are able to retrain very much more easily than like a 50-year-old that you're trying to do an MMA on. So the problem is a lot of these patients come to me with sleep apnea that they've developed later in life. And so that's where you kind of have to look at different ways. And sometimes it's multi-modality treatment.
Yeah. Are there any other auxiliary treatments like Inspire that you think are kind of flying under the radar, especially with audiences like mine that are focused on bone structure?
Yeah, I mean, there's some interesting, there's some interesting things that are coming out, like new medications that are going to be FDA approved for sleep apnea, where We think that maybe it's a combination of oxybutynin and atomoxetine. So it's kind of like an upper and a downer, but it's supposed to improve the muscle tone. So you take it kind of right before bed, and it helps improve muscle tone, but also kind of helps you sleep better. So there's different things that, maybe down the road we're going to use as adjuvant treatments. Some patients, even after MMA, if they're still super light sleepers and arousing, do they need some kind of medication like a trazodone, which is an antidepressant, but causes people to get into a deeper sleep? Things that you can kind of address medically. Or I had a patient that we did an MMA on that, they got 50% better, but they still had kind of more, bigger tonsil tissue, which they didn't want to address initially. And now, I'm trying to be like, hey, we got to go back in because I did a DISE and your tonsils are still collapsing. So in the real world, or in the ideal scenario, I probably would have taken them out first, let her heal, and then done the MMA. But, I think kind of reevaluating things after, if you've done a jaw surgery, to figure out, like, if you're still having issues, it's probably because there was some other factor other than your jaw structure that was contributing to it.
Yeah. Wow. Yeah, man, you're like an interdisciplinary sleep team, but all in one person.
I try to be. I'm trying to kind of look at. I mean, it's hard because I try to look at it from my sleep medicine physiology training to the ENT training to the craniofacial training, and so it's trying to kind of marry all of those together, which sometimes makes for long visits, but it's fun. I love it. I mean, I'm super passionate about sleep apnea and airway stuff, and I think the field is growing, and I think we're learning more about it, and it's definitely a cool spot to be in.
Awesome. Dr. Hutz, thank you for your time today. Really appreciate it.
Yeah, thanks for having me, Ron.
All right. Bye-bye.
Take care.